Hello everyone and welcome back. Something a little bit different today. This patient was referred over by one of my good referrals, but look at the curve on the mesial. And this sparked a conversation of why would the dentist even try this in the first place, which allows me to get into quite the little soapbox here. So without further ado, let's talk about general dentists doing maxillary and molar root canals. So the first thing I want to go into is I'm not the endodontist who's out there saying that only endodontists should be the ones who do root canals. That being said, I don't see any good reason that a general dentist should do maxillary first molars for root canals. And there's a few different reasons why. Just to show you, I know that there are so many root canals done this year. So there's about 15 million root canals done per year in the United States. There are about 5,700 endodontists. And if you consider most of us work 4 days a week, if we were to push that out through the year, there would be about 78,000 root canals performed per day. And with that number, you'd have to do 13 root canals per day per endodontist. And I don't know many endodontists who do more than, say, 5, 6, maybe 7 in a day, sometimes 8, but 13 is insane. So I know that we need general dentists to do root canals. My point here is maybe we don't need you guys to do maxillary molars. And let's talk about a few of the reasons why. So a little bit of math for everybody. I've always been a numbers nerd. If you can't tell by everything about me, I've always been a nerd. For general practitioners, the average fee, if you look from the ADA survey of dental fees for a molar root canal, is $1,223, okay? The average crown fee is $1,316. And a lot of you are going to be saying, those are not the numbers in my practice, and I totally get that. I'll get into that in just a second. The average chair time, let's assume from what I've gathered, having worked in multiple general dentist offices and hearing from patients, in general, to do a molar root canal, it's going to take most general dentists about 2 hours. And to do a crown, if you're going to do it in a single visit, it's going to take usually about 2 hours with the milling time and some cementation and all that. And then if you're doing it over 2 appointments, it'll probably take 2 single-hour appointments as well. So in general, let's just make some assumptions that it will take you about the same time to do a molar root canal or a crown. The difference, though, is how much time it requires of the general dentist in the chair. There are very few things that assistants can do during a root canal. So my estimation, based on what I have to do, is about 90% of the time has to be the dentist in the chair actively working, which means you cannot be doing anything else. You can maybe get up and do a hygiene check, but it's not like the assistant can really do anything for you in the meantime. For a crown, however, the assistants, especially if you're in a state that allows expanded function, can do so much. They can design the crown, try the crown in some states even cement the crown. So I have friends in California where they have EF2s, and their job is to prep the crown and get out of there. That takes them maybe 15 minutes, maybe 30. I went with 25% of the time. The dentist has to be present in the room for that. And this is where it becomes really obvious why, if you're busy enough, you should be doing crowns. You should never be doing maxillary molars. If we look at how much a dentist makes, and this is based off of Kane Waters, I was looking at a few different dental offices, looked at their total income during that year, and this is for owners, once again. If you look at the amount of time that you spend and have that be kind of the salary and put it out to a how much does it cost per hour, with 90% of the time doing a root canal, it's going to cost the dentist about $550 in their quote unquote salary versus a crown, which would only be $160. Now, if you consume the overhead, this is also from Kane Waters, of about 60%, you're actually losing about $60 every root canal that you do. If you take this long, if you make this much, if this is what your amount is going to be, versus a crown where you are making an additional $366. And some of you are saying, well, I want to do it because the endodontist is so much more expensive. When we look at the ADA fees, it's only a few $100s more to have us do it. And on average, I'm in there for about 45 minutes, maybe a couple appointments at 30 minutes a piece. But in general, if your argument is, oh, I'm going to be so much more affordable than the endodontist, that's not really the case based on these numbers. Now, if you're an associate, those numbers aren't going to mean anything to you because that's not how you get paid. So we're going to use these same numbers from the ADA and from CEWA and look at, okay, how much does it matter for the associate? So the average associate gets about 33% of collections. This is from the Dental Economics Report. Once again, put your own numbers in here. It's easy to see how it's going to work for you. And if you're doing a root canal at 33% collections, and you have to do 90% of the time in there, you will make about $224 an hour from that procedure. Now, obviously, there's a lot of other factors that come into this, but notice the next part. if you are only having to spend the 30 minutes doing that crown, you're making over $1,700 an hour. So the math here really comes down to, is it worth it for you to do the time? And the other thing you have to consider is these are for fee-for-service practices. These are in the most ideal situations. If you're dealing with insurance, I've seen general dentists get $500 for a molar root canal. And if it's $500 for a molar root canal versus, $1,000 for a crown, it's clear that you should do the crown instead. So factor this in, put the numbers in yourself, and see if it's even worth it from a financial standpoint to do this. The other thing is think about the patient experience. Some of you might be saying, well, I'm a fee-for-service dentist. I can charge whatever I want. I've seen general dentists charge $1,800 for a molar root canal. But the way that you're able to get patients to pay that much is you give them an experience that is beyond what the normal general dentist can do. Go watch my presentation on what the bear taught me about root canals. If you want to give them that great experience, part of that is how long does it take for you to do it? And I guarantee I'm going to be more efficient and find everything where they don't have to come back for multiple appointments. They don't have to have it retreated than the average general dentist just because of the microscope, because of the cone beam, and because of the experience here. So if your argument is, well, it doesn't matter to me, I can charge whatever I want. Remember, there's a reason those patients are coming to you, and that's because you provide that next level of experience. Allow the endodontist to provide that next level of experience for you as well. And really what this comes down to is the schedule busy? Because if your options are do nothing versus do a root canal, do the root canal. I get it. If we're kind of going into a potential recession, potentially, I don't know. We don't really like to say that word, but things are definitely weird right now in the economy. And so people aren't really spending the money out there. So if you don't have anything to do the root canal. My argument is if you are busy, if you are booked out a few weeks, there should be no reason you ever do a root canal. These are money-losing procedures for you. Now, I know some people who love doing root canals, and if that's the case, go for it. Go do your root canals. Go have fun. I'm not here to yuck anybody's yum. I know plenty of general dentists who love doing root canals, and it brings them joy. And there is more to life than just money. But if you're looking at it and saying, I don't want to send a root canal out to an endodontist because I'm losing money every time I do that, put your numbers in. I think you'd be surprised how you may actually be saving yourself money and certainly time by not doing the root canal yourself. Okay. I also wanted to give a little bit here on buildups. If you've seen my channel, you know I prefer to place the restorative because it's better for the patient, it's better for the tooth. In many cases, it's better for the general dentist as well. And when we apply these numbers here, this is a case I just did literally yesterday, okay? You can see super deep caries. I normally don't restore for this doc, but he did ask me on this one, probably because of the complexity of this case, the angle and everything like that. This patient is under insurance. I'm not going to say which one because I think that would violate a contract, but here are the rates that I got. And I actually videoed this one, so I had the time for how long it took me to do everything. For just the root canal, I was paid a little over $1,000, and it took me 17 minutes from the time I started with a burr to the time I stood up to take the check film. Normally, at this case, if I was going to be not restoring, my assistants would take the X-ray, they would put the cavet in there, they'd set everything out. So my actual working time from the time that the rubber dam was on when I walked in to the time that I stood up was just 17 minutes. That works out to $3,600 an hour, which is insane. Now, I'm not going to stack my schedule like this. If you look at every endo guru who tells you how to be, wealthy in endo, this is what they tell you. This is the quote unquote Michigan method, which is I know endodontists who hire hygienists, so they don't have to diagnose, they don't have to place the rubber dam, they don't have to get patients numb. They walk in, they do just the root canal, and the staff does everything else. And they drive Ferraris and have beautiful, huge practices and see 4 patients in an hour, and that is not how I like to practice. But if your argument is, hey, endodontist, don't do the restorative because you're stealing money from me, that is definitely incorrect. This is a money-losing procedure for us 100% of the time. When you look at the actual case, I did some deep marginal elevation and tried to straighten the tooth up for the dentist, tried to make it a little bit easier for him. It was a mess to get this built up inside there. It actually took me 22 minutes to do the restorative on here. I had to get a new rubber dam, I had to get the gingiva under control, building it up, removing the decay, removing the restorative material. It was a lot more time. So it actually took me far longer to do the restorative, which I was only paid $228 for, than it did the actual root canal. canal. So my point here is, if you have an endodontist who does restorative for you, do not think that we're doing that to take money away from you, that we're doing that as a money-making venture. I lose money every single time I do the restorative for a patient. The reason I do it is because it's the best thing for the patient, it's the best thing for the tooth. And if you're a general dentist, which one would you rather prep? Would you rather come back in and have this bloody mess with an open hole and a bunch of cavit and sponge in there? Or would you rather prep the tooth on the right-hand side that's ready to go? I mean, pretty much he's got to put the buccal lingual margin on, take an impression, and he's good to go. So sorry for getting on the high horse here. I had a negative interaction with the general dentist who got really upset that I had restored a tooth. It was a miscommunication on his staff's part. But the point is, we're not doing this to make money. We're doing this because it's the right thing to do. All right, so let's go ahead and treat this tooth. First things first, let's flatten out those buccal cusps. Just make sure you don't have any interferences using the wheel burr. And you'll notice here they used my favorite material in the entire world, IRM. The reason I have such a vendetta against it is look at how fast my mirror gets completely destroyed. This thing has been coated with my hydrophobic solution. Please stop using IRM. Cavit works so much better. I'll show you the difference when you re-access through Cavit here in just a second. It's night and day. The other thing, stop using cotton pellets. Foam works so much better. Take a piece of the sponge, throw it in there. It's not going to bind up on your burr when you go back inside there. It makes such a difference here. Rinsing everything out, you'll also see the access is way too far to the distal. I'll go into a lot more detail in this in just a second here. But before I do that, I want to show you the difference between re-accessing a tooth with Cavit. So here's one that I did recently. Notice how clean it is. How even though there is a small amount when we hit that's actually the calcium hydroxide that's flying everywhere. That's not the Cavit. The Cavit doesn't leave a mess like the other one. I probably should have used one with the mirror so you could see it more visually, but it makes such a difference doing Cavit versus the IRM. As I'm cleaning that out, you can see, even though that broke down a little bit and there's food, the mirror is still crystal clear, and notice how that sponge popped out immediately. All right, second mistake that general dentists make is access design. So you've already seen a few things as far as what we're looking at inside this tooth. This general dentist is fantastic. I've known him for a long time. He's very talented, but how he designed this access is how we learned in dental school, which is you take a big old round burr and you go right down the middle of the tooth. And for maxillary molars, that is the exact opposite of what you want to do. For pretty much every other tooth in the mouth, it works pretty well, to be fair. You'll notice on all my cases, I don't access into any tooth using the round burr. I use round burrs to drill through crowns, I use round burrs to drill through other restorative material, and I use round burrs to remove caries. Once I'm in tooth structure and doing the actual root canal, it's only long, skinny diamonds, the workhorse burr. Hey, I said it right. And that's what you want to kind of think about here, is how we're going to design this tooth, because there was excessive removal of dentin along the distal, and I'll show you that in just a second. This is from a paper in 2018 looking at kind of different endodontic access cavity types. You'll see on the left-hand side, that number 2 there, I just posted a case recently on the ultra conservative accesses. It was on a maxillary molar. When you can do that, that's great. The only way you're doing this is with a microscope for sure. Most of the time, I try to get the middle one there, that number 3, where you see it's not quite a circle, it's more kind of like an oblong, but imagine where the MB1, MB2 palatal and distal will be, and you'll see that's the shape that it forms. Really, the shape on the right-hand side, that's almost too large even for me. Every now and then you do have to do that, and retreats are definitely a different situation as well. I'm talking about if it's the first time inside the tooth, but you want to keep things small, and most importantly, don't go through that oblique ridge. That's a very strong structural component of the tooth, and if you can avoid doing that, the tooth will have a much better longevity. So the question is, why are we taught to do larger accesses? Why do we see that they're why so big? And really what this comes down to is a combination of a few different things. So first is tradition. If you talk to any old endodontist, their whole thing is you have to see all the canals. That's how I was taught to do it in dental school. That's how probably all of you were taught how to do it. You need to have quote unquote straight line access. And the reason why is because our old files were so stiff, they wouldn't go around curves. So you had to create parallel designs to make sure that you could remove enough tooth structure so you limited the risk of file fracture when you're doing the actual case. Straighten it out, that way you don't have as much stress on the file. Now, the new files we use are so small and flexible, that is no longer an issue. The next reason we had these large accesses is you couldn't see anything. Back in the day, it was just what your eyes could see. Loops came out and, they're at like maybe 2.5, 4. Some endodontists back in the day had 6s, which is pretty cool. But I start at 4, and most of the time I'm flipping between 10 and 16 times magnification. And you are able to see so much more through such a small hole compared to what we used to, that you do not have to make the holes as large as you do, which means the teeth are so much stronger. And then the final reason actually is light. When you look at the headlights that we have, so we have different lights. You got the overhead light that you have to kind of bounce into the tooth, and really they're not that bright. If you look at an overhead light, like one mounted on your head or on your loops, yes, those can get pretty bright, but once again, they're nothing compared to the one that I have in my microscope. The xenon bulbs in my microscope are brighter than the ones I have in my car, and they fire straight down into a small axis. I have never had an issue with being able to see. So these 3 things here, we've always done it this way, which if you've ever seen any of my presentations, you know I hate, and the ability to see more, to magnify what you're seeing, coupled with the ability to actually be able to visualize it based on the light, means we have changed the idea of what it means to even access a tooth anymore. So this is one I found from a different YouTube channel. That's terrible. I hate everything about this as far as the design. Yes, it definitely, this would get an A+ in most dental schools in this country because you can see everything, all the chambers been unroofed, but here's the problem. Prep it for a crown. What's left? So little tooth structure remains that this tooth is now structurally compromised, and the chance of it failing has dramatically increased. Couple that with the case that I did the other day. That's barely 1.5 millimeters. When you prep it for a crown, look at how much tooth structure still remains. This is why, especially on maxillary molars where they're difficult to see, just send it to the endodontist. They're going to drill a smaller hole. They're going to give you more tooth structure to work with, and that's the key thing. You want to have as much, if you ask any general dentist, what do you want? You want to have as much good tooth structure to work with. It's far easier to put a crown on a completely natural tooth that you're doing for aesthetic reasons than a broken down tooth, because now you have to build it up and now the tooth is compromised. Another thing here is the case is off-centered, and this is actually the case here. The image on the right is a still from the video, but you can see how much extra dentin was removed distal to the palatal and the DB canals that never needed to be there. We're going to use a little bit of design here, and I decided to do pink and sparkly in honor of my little daughter. This is how I generally would start off my access, and then if you need to find an MB2, you'd kind of come along here and adjust it like that. If we're doing a more traditional, larger access, there's no reason to drop it down distal to the palatal and the DB like you saw. This area right here never had to be touched, and it did weaken the tooth. All right, enough of the very preachy lecture. I think I was in a mood when I recorded that one, so I do apologize to everybody. At this point, what we need to now do is find MB2. So they're able to find the 3 main canals, but had a little bit of difficulty with the MB2. So if you've seen my videos before, you kind of know the process. One thing I did differently here is, given the severe curvature on this tooth, the first file I really wanted to put down here was something very small, so that's why I'm going with a 6C. You're not going to ledge out your case with a 6C. As you can see, I had no any ability to get inside that MB2. So I'm going to use a 1303 incredibly small and flexible file here to start to get that initial glide path. One of the things I often find is that general dentists, when they try to do that initial cleaning and shaping, especially on a longer, curvy case like this, you'll find that they often ledge out the case. And so if you're an endodontist who's having to retreat cases that have been previously accessed, one of the things you can do is start with that really skinny file to help almost as like a glide path. The rotation will allow it to get around ledges better than a straight file would. And I felt really confident with the 3 main canals. They were not too bad. This case ended up being quite long, but I took the 2006 down just to make sure there wasn't any impediments. It's a great file for this sort of thing. As you can see, still having some issues with that MB2, and this is kind of what to expect. When you're doing maxillary molars, you're going to spend the bulk of your time on MB2. The other 3 canals are usually really straightforward, but I wasn't able to get down anything, so going back with the workhorse here, almost said that correctly there, we're getting better. The vocal lessons are paying off. Actually, I don't take vocal lessons, but I probably should at this point. Anyway, Using the skinny workhorse here, the 012, just to kind of open it up. And I will usually flip between using an 8C or a 6C. The 8 is nice because it's a little stiffer. So if I have to put some apical pressure on it, it makes a difference. But we're already down about 2-3 millimeters, and I'm not really getting into anything. So I switched over to the EG3 burr here just to make sure we're as conservative as possible. Even with the 012 850, that workhorse, it's still a little bit too aggressive for my taste when I'm down this far. You'll see me kind of pop between the two burrs here. I like to use the EG3 almost as an initial troughing burr and then kind of flatten out anything excess with the workhorse just to make sure we have a nice flat surface. I've found that if you use just the EG3, it's difficult to get the 6 or 8 C file to bind. Whereas if you have a flat surface like this, you can kind of almost play along. You can see where that white stripe along there, that is where you're going to find your canal, and it's easier to push apically when it's flat rather than when you have a point from the EG3. So I was able to get a little bit of a stick here, and I'm going to use that 17 to try to open that up. You can see how it's moving. Look at it, we've already moved almost a millimeter buccally, and that is what you usually see with MB2s. This is one of the main reasons I don't recommend general dentists do maxillary molars, is because MB2s are a pain in the ass. Sorry for the language there, but they are the bane of our existence. And as I taught the residents, they are how you pay off your student loans, because MB2s are incredibly, incredibly hard to find and negotiate without the help of a microscope. So you can see me flipping through a bunch of different burrs here. We have the 2006. Right now I'm using that 13 just to try to get a little bit of this open. Remember, this tooth has an almost 90-degree curve on it. So that sharp right angle means it's very difficult. At this point, though, let's go ahead and get working length, get everything figured out. I skipped over that because you guys have seen it before. And we're going to use that 1704 to do the bulk majority of our work here. You can see me turning to the side so I can see the length here. And notice this is a 25 length. So that's another reason you want to avoid doing maxillary molars if you're a general dentist, is because as they become longer, your risk of file separation goes up, I would say exponentially. The longer the cases are and the more curvy they are, the more you risk having an issue. So I'm still going to use that 2006 here. I just use it in a 21. I don't really need to take it to the full length. That's probably a little too aggressive for my taste, but I do like to use it to flare, especially on a curved case like this. I am kind of going back to those original principles of straight line access. I am flaring so that my small files only have to work in the apical bit. And as you can see, this is a lot of files. This is a lot of going back and forth. And even still, I was not able to get the working length on that MB2 without using the rotary there. So you can see me finally getting my MB2 length, making sure we are back down to the proper level here. And even with all this, we still have some more work to do. That's the beautiful thing about these cases, is they just never seem to end. So finally getting down there with that 13, and really happy with how that turned out. We're finally to length there. I'm going to leave it at a 13 for the finish. I will flare a little bit with the 2006 just because the 13 is too tiny to fit that 25 gauge on the beta. I do need to have it a little bit bigger. And then kind of to even out that transition from the 20 to the 13, I'll take the 17 down to pretty close to working length. We're almost there, as you can see by that stopper. I think working length here was like about 23. All right, the third mistake that general dentists make isn't really their fault. It's just the files that they're taught to use. Primarily, there's two problems. They're either way too large or way too stiff. Now, if you want to learn how to do root canals, you call up this company here. They have some of the best reps in the business. They will be at your office with everything you need. They will walk you from start to finish how to do a root canal on a live patient right there. I have feelings about that. I think most endodontists do. But here's the thing about Wave 1 and reciprocating files in general. They are not an inherently bad system. They actually, in my opinion, are a really nice test for a general dentist. Can you do the root canal with these? If you can, then that's a root canal you should be doing. But if you can't do a root canal with Wave 1, send it out. If it's too calcified, if it's too curvy, if you're having difficulty finding the canals, then send it out. I like to think of Wave 1 and the similar files, all of the different companies make this at this point. I like to think of them as kind of this, test, really. If you can do it, then that's probably the right case for you. But in general, when we are looking at maxillary molars, they tend to have some skinny roots, especially on the distal buccal and the MB2. They tend to be very curvy. And so these stiff files, even if they're the Wave 1 Gold, are still going to be too stiff to negotiate most of these cases without transporting or causing damage to the tooth. The other thing is they're way, way, way too big. We do not need to remove this tooth structure. It's been shown time and time again that it doesn't matter what file system you use, you're not touching all the walls. It's not necessary to touch all the walls to have success. We've shown that. I have 10 years of cases showing that I have not touched the walls, and I don't have a flood of failures coming in. I see maybe one failure of mine a year, and it's usually a vertical root fracture, okay? Once again, the way that I look at this is, can you hang a picture with them? If you look at these files right here, these big old fatties, you can imagine taking that pointed end and a hammer, hitting it into the wall, and putting a picture on there. If you can do that, do not use those files for anything besides an anterior tooth. And if you look at the files that I tend to use, on the right-hand side there, that is actually the dimensions of all the different sizes. So I usually use the 17 and the 20 there, and they tend to have three things in common. They tend to be heat treated, which means that they're going to be very, very flexible. They tend to have a small maximum file diameter. By the way, I don't know why the AI system that helped me design this decided that a dinosaur was the proper little icon for this, but it made me laugh, so I kept it in there. And the question is, can you tie them in a knot? My 17 files, I can literally tie them into a knot if they're long enough. It's amazing how flexible these things are. And when you look at the information provided by Bressler on the right, the size at 5 millimeters up on the 17 is a 35, and on the 20 is about a 50. And the maximum diameter of the flutes on the 17 is only 0.55, and on the 20 it's a 0.7. Most of the cases I finish, I will use the 17 to length, and I'll just take the 20 over the top to make sure I can get the tip of my gun into the squirt technique. Compare that with some competitors. Even the new ones that are smaller still are up at a millimeter. And if you look at something like the Wave 1 or the traditional Pro Tapers, they're up at 1.2 or 1.3. Now, we're talking in millimeters. That doesn't sound like a lot, but 0.55 compared to 1.2, it's literally twice as large and removes twice as much tooth structure, therefore weakening the tooth. So if you're going to be trying to do these cases, don't use the large files. Learn how to use smaller files. Learn to fill these small shapes and learn how to clean these cases out as well. The final mistake that people make is MB2. This is actually the case here, as you can see, where it started was right here, and it moved all the way over here. Now, I have seen plenty of examples of lecturers, especially general dentists, going up and saying, you don't need to worry about MB2. They join most of the time. They don't exist. They're only there about 50% of the time. And so if you saw one of my earlier videos, I've embarked on this quest to do my own study, which is look at all the cases that I do and use photographic evidence, if not radiographic, you'll see them here in a second, to show what is the actual incidence of MB2. So let's go through my cases. So let's go through my cases for September. So this is the famous drawing that I do on almost all the reachers that I do, and you can see the missed MB2 there. So we have an MB2. We have kind of an MB2. This one was one where it joined up and kind of went in. So let's say this one was a type 2, but certainly not just a single MB2. 2 MBs there, 2 MBs there. Another one where it kind of joined up. You can see a little bit different, but I did have to do some troughing there to pick it up. 2 MBs, 2 MBs, 2 MBs, 2 MBs, 2 MBs. And let's go into October. Guess what? 2 MBs, 2 MBs. Another one of that famous drawing, 2 MBs. There's the correlating one that you saw earlier. That was the missed MB2 in that case. Another MB2 missed. This one actually I think is going to be cracked, but I included it because I did find the MB2. Fun fact, for some reason those vertical root fractures love to go down the MB2. No idea why on that one. Another MB2, and that's actually the case that we just did here. So when we look at the total numbers of the MB2s that I have found over the previous 3 months, including the presentation that's earlier, there were 35 maxillary first molars that I did. 33 of them had 2 separate orifices that stayed separate throughout the entire treatment. Only 2 of them were type 2, leading to an MB2 incidence of 100%, and only 5.7% of them joined. Now, we could definitely do a cone beam study and look at do they join farther down, but I've shown multiple times that even if they are that traditional type 2 where it joins inside the canal system and doesn't have a separate exit, that can still cause failures. It is still important to find and clean and shape every single MB2, which leads me to my final point, find MB2. All right, let's go ahead and finish this case up here. So at this point, we are now patent. Everything's looking great. We're going to go ahead and do our final rinse here with the rest of the Triton. Go ahead and use the activator here. This yellow tip is a really nice option for these skinny, long, curvy canals. The old school red one that I would use really wouldn't fit these quite nicely. The yellow one does a nice job getting down around those curves, and the more debris you can remove, the better obturation you're going to have, and I guess the better prognosis the tooth has. Go ahead and dry everything like normal, air dry that, make sure everything looks nice, and then we're going to come in with our paper points here. So you can see that curve on the MB2 and see where it started and where it ended up. I always am so amazed at how much these can move from where you start to where they actually end up, and it's because those first 2 millimeters, you're just going to have kind of that S curve, and oftentimes it'll move. The other thing hopefully you can see here is just how much extra dentin was removed around that distal canal. And that's just because, like I said, the general dentist, that's how they were taught to do things. But if you're going to be doing maxillary molars, try to stray a little bit more towards the mesial. You'll notice here for the recapitulation, I'm using a 15K file, and it's going to be a 25 length just because of the curve in here. If you remember my video on treating severely curved canals or calcified cases, oftentimes I will drop down to a 15K file instead of a 20 because it's going to go around the curves and negotiate it a little bit better. On a case like this, I am going to be doing the squirt technique here. It is very important to make sure you have a clear path all the way down to the very end of the tooth. With the squirt technique here, there's not too much changes. I'm doing a little bit more pressure with the condenser there than maybe I would on a wide open case, but otherwise nothing really excessive. Same thing MB2, it's going to follow pretty much the same path as the MB1. So when you're doing these, and I kept the whole squirt technique in. I know some of you have asked questions about it in the past, so hopefully seeing a few extra will be beneficial. If there's something you want to see in particular, let me know. My advice, go out there and just start trying it. You need to, everyone's going to have your first case. Make it an easy one. Do not do it on a calcified, curvy tooth for sure. Don't have that be the first case you try the squirt technique on. I didn't think I had to tell anybody that. But like a nice anterior or a single canal bicuspid, nothing, with a large infection. And that's what I recommend. So as far as the rest of the case, you've seen this before. Tamp it down, make it look pretty. I am going to use the PacMac here, and the consideration for the PacMac is, you want to remove any voids, but you also don't want to break off any parts of the file. If you've ever used a PacMac before, you try to take it too far, or especially around a curve, very likely that you're going to break a tip off, and sometimes they're very difficult to remove. So in this case, I'm just going to be using the 21 millimeter length. I don't really see any benefit of using the 25 here because I'm only going to go in. You can see I'm only dropping down about maybe 4 or 5 millimeters on the distal buccal and palatal, and I'm going to be even less on those mesials. And you're saying, Scott, well, what's even the point of it? The cool thing about this is it almost has a wave that pushes forward. So I found that the case, even if you only go in 3-4 millimeters, it can usually fix any voids that are down at that, 5-10 millimeter mark as well. So what we're doing here is just finishing it up. I did notice there was some IRM still stuck up in those chambers, and I am going to be doing the restorative for this dentist. So you just want to go in and remove that. Nothing excessive here. Just want to make sure that everything is nice and clean and you have a great foundation with which to repair this tooth. So hopefully this is kind of an interesting case for everybody. We're just going to be finishing up here with restorative, but I think it's really hopefully clear that for most general dentists, maxillary molar root canals isn't a good option for you. So we took a check film. You can see I used the yellow etch there, and there was a nice big old void in the palatal. So going back down, I kept this in because it is funny. Sometimes it will grab those little guys. And then there was a little bit of void in the MB as well. So I am going slightly farther here. So like I said, sometimes there'll be a wave that pushes it forward, but before you take it to that length and risk breaking it, I think it's worth it to take a quick check film, make sure everything looks great, and go from there. So refill those spots, and that's one of the things. If you notice that it drops down, generally what you'll see is the gutta percha will drop down a couple millimeters, and that's because it is now filled in the void. That is a good sign. I'm still going to take a check film. I was definitely the type of person who wants to make sure everything looks perfect. Because the palatal was a little bit funky, and these were all, I'm just trying to make sure because of the curves that we have the best possible obturation. So that one looked really good as far as the check film, and we're going to get ready to seal up the coronal aspect of the tooth. tooth. So use the disclosing solution, blast it all away to make sure it's nothing nasty inside there. You will notice that when you use IRM, there is almost more bacterial activity. And I think it's because of the eugenol. There are certain types of bacteria that are more attracted to eugenol in particular. And we see this a lot with eugenol-based sealers, that they can cause staining over time. I think it's because they're more attracted to bacteria. So that's what it looks like when it's all cleaned out. You can see where that MB2 started and where it finished. Gotta love that movement there. We're going to go ahead and repair the tooth, build it all up. So using the clear fill for this one, you can see I'm going around the occlusal aspect here. I think there's just a little bit of dust that I wanted to make sure didn't get inside there. That's the one thing with sandblasting, is it does make a mess. Unfortunately, that is the downside with it, is it does make a mess. So this is the 2-bottle system. Like I said in my other videos, we are loving that 1-bottle system. So once we blow through this 2-bottle one, it's going to be 1-bottle universal. I've had great results. I've done some aesthetic cases. I've done lots of single holes like this. It's been working extremely nicely. So I'm going to use the A3 in a brown tube. Very easy to shape this, make it nice and clean, and then we'll polish it off, make sure the bite's good, and call it a day. So hopefully this has been an interesting case, as I was saying. If you want to learn more about doing maxillary molars and you're a general dentist, I highly encourage you to do that. That's, if you like doing endo, I'm never going to say, no, don't do it. If you're doing it because you think it's going to make you money, you're doing it for the wrong reason. Don't do that. I would also recommend that if you are going to start doing maxillary molars, that you get a microscope. You cannot find MB2 most of the time without it. That was always the calling card of the endodontist back in the day, is, oh, what's your MB2 rate? And when you just had loops or bare eyes, you were pretty darn good if you were at about 50%. And as I've shown, we are pretty much at 100 at this point. So that's what it looks like when it's all sealed up. It looks nice and solid. And the moment everyone's been waiting for, check out those curves, MB2, and check out the curve on the palatal as well. Really, really cool case here. I just love how everything looks. But thank you all so much for watching. Hopefully this is an interesting one for you. It's a little bit longer, but I thought it was talking about this case with the Discord group definitely brought up a lot of different conversations, and I figured I should bring it to the World Wide Web and see what you all had to say about it. But as always, thank you so much for watching. Please like and subscribe. If you have any other questions, comments, videos you'd like to see, please drop a reply below. I reply to all of them, and I will talk to all of you next time.